To begin, I'm just going to say a few words about the Canadian Primary Care Research Consortium. The consortium is a Canada-wide group dedicated to strengthening and scaling primary care research across the country, founded through the partnership of primary care researchers and clinicians, patients, policy and decision makers, and practice-based research and learning networks. The consortium strives to be a home for all primary care research. We work to improve the visibility of primary care through our developing data platform of electronic medical record data linked to practice and patient survey data. Together, we are fostering innovation, advancing patient-centered care, and ensuring that research directly informs practice and policy so that primary care in Canada continues to grow stronger and deliver better health outcomes for all. So we are very fortunate to have been invited by the consortium. I'm just going to bring up my slides. Start sharing. Just can I get a thumbs up that that's received my slides? Good, great. And so this is learning series number 3 from 2025. And we are talking about royalty-based primary care in Prince Edward Island and the ongoing work that's happening here, as well as in many other provinces that is changing the landscape of how primary care is being delivered. So this is session number 3 of learning series number 3. And we're calling this Stopping for Fuel. And today we're really going to talk about capacity building and how to support existing clinicians, as well as the resources that are going to be provided for those ahead. So I'm going to go through, we'll do our land acknowledgement. We're going to have some brief presentations from our panelists. There'll be some question and answer time, and we'll open that up to those that have joined, and then we'll conclude with a few closing remarks. And so to begin, here in PEI, we are situated on Epwick, and we acknowledge the land upon which we gather is unceded Mi'kmaq territory, and it's covered by the historic treaties of peace and friendship. We pay our respects to the Indigenous Mi'kmaq people who have occupied this land for over 12,000 years, past, present, and future. And we acknowledge that many of you from across the rest of the country are coming from your respective places. Historically, I would have said put that into the chat, but that's not part of our feature today. So we'll just continue and hope that you find yourself grateful for the land that you are situated on. Just a technical piece. We will go through our introduction piece here. There's a Q&A box that you can present your questions in. You can type them into there. Or alternatively, when we get to the discussion period, if you have a question and are comfortable coming on audio, you can raise your hand and then we'll enable you to participate that way. A little bit about me. And so I've been coordinating this and I moderated session 1 and spoke in session 2. And I'll be moderating again today. So I'm a health system impact scientist here at University of Prince Edward Island, and spend my time in the Health Research Network investigating access to care, particularly around access to primary care. To do a quick recap, session 1, we provided an orientation to the primary care roadmap, which is really the document that was provided by the Department of Health and Wellness here to initiate transformation towards team-based care in Prince Edward Island. You can access that. The slides and recording are posted, as is for session number 2. And I'm just actually going to skip over that for a minute. Session number 2. I'm going to recap that a little bit more detail because we spent a lot of time talking about our own scoping study that we were doing here within the Health Research Network, but as well, we had a panelist from Health PEI speaking about the work that's already happened, the steps that are being taken towards implementation of team-based care. And so our work is really describing what rural team-based primary care looks like across Canada. And this sort of conceptual diagram is one that I like to use when we say patient medical home, which is the terminology that we use here. Not all homes are the same. And so what are the different ways that we can describe the characteristics of what a patient medical home looks like when they show up in different ways in different places? Similarly, Health PEI presented about the steps taken and that this is an incremental process, that there's ongoing efforts to continue to build and improve access to care, and that's changing the way that teams work, the different members of the team. And so there's a maturity process that happens as implementation of team-based care takes hold. Yeah, I kind of spoke to that already in terms of this slide. Being able to categorize present state about this is the state of how a home is functioning now, and then coming back in a year's time to look at what has changed in terms of the service delivery model. So session number 3, I've spoken about it a little bit, really, and the idea for all of these sessions has been trying to make them as engaging and conversational as we can. And so we've got some great panelists today. We're going to be talking about building capacity in primary care. We're going to be talking about supporting existing clinicians. And then where do we go? Like, what does the future hold? So with that, I'm going to play. Let me hope that this works. We have a short video. That it's not playing. And now I gotta stop for just a moment. Apologies. Let's see if we can. It's going again. Does not seem to be working for me.
Islanders are far too familiar with the challenges facing today's healthcare system here at home and across the.
I had audio, but I didn't. The video wasn't playing. Was that, were people seeing the video?
No to the video, but could hear the audio.
Yeah, I'm gonna just try it. move past this. So, stand by.
Country. Challenges with
Okay. And what is visible on the screen now?
Dr. Smith's panelist slide.
Okay. So my screen is not showing that. I'm going to let Dr. Preston Smith take a minute to introduce himself, and I will address these technical issues.
So good afternoon, everyone. My name is Preston Smith. Obviously, on the slide, I'm a family doctor, and I am the inaugural dean of the Faculty of Medicine for the Joint Program at the University of Prince Edward Island. I did comprehensive family medicine for many years in Moncton, and then pursued an academic career at Dalhousie. And then last 10 years, prior to coming to PI, I was the dean at the University of Saskatchewan. And yeah, so. Do you want me to just talk about the slideshow, Matthew?
You are welcome to, or we can hold that and I will continue to try my efforts, and maybe we can get that in before we start into the panelist. So
Sure.
let's do that. Let's go to, because also I feel like this is a convenient time. Adam, if you want to introduce yourself, and if you want to attempt to share your slides, then maybe that resets my slide deck while we're in this space.
Happy to. Well, hello to everyone out there. My name's Adam Reed. I am currently an education specialist working at Memorial University's Center for Collaborative Health Professional Education. Prior to that, I spent about 12 years coordinating interprofessional education activities for students from medicine, nursing, pharmacy, social work, psychology, kinesiology, and recreation therapy programs here in St. John's and across the province of Newfoundland and Labrador. We have outreach programs with practicing teams across the healthcare system over our tenure as well. I am also a PhD candidate in community health, and where I am looking at the relationship between team-based primary care and the well-being of those care providers who work in those teams. So that is my area of focus. That's where I'm coming from now. I'm currently developing training opportunities for Newfoundland and Labrador's family care teams, a recent political and health and social care structural addition to the province. And Matthew, you're asking me to try and see if maybe I can share my screen with our panelists. Is that right?
If you had slides to share, you are welcome to share them at this time.
Let's give it a try. So if this worked, you should be seeing my title slide here.
There we go.
Is that right?
Yep.
Shall I continue, or are we just hoping to see if we can kind of reboot the system?
You go ahead and share those, and then we'll come back to me.
Alrighty. Well, my objective here with my time is to give you a feel for some of the context and the developments that have taken place over here in Newfoundland and Labrador. We're excited to have a relationship with the University of Prince Edward Island, and hello to Megan, one of our MD candidates over there as well. Good to have you on board. Not unlike Prince Edward Island, we have a fundamentally rural province. About half of our 500,000 and change citizens of the province live on the northern Avalon Peninsula, primarily in St. John's, Mount Pearl, Paradise, where I'm coming to you from today. And the rest are distributed across Newfoundland, the 16th largest island in the world, in rural communities, and it gets even more distributed in Labrador, which is far larger and has a population of only about 26,000 people. So we have a number of challenges that come along with that. How to distribute and make accessible the health and social care services that everybody needs in an equitable and accessible way. So that is what we're looking at. We have what is actually the highest per capita spending among Canadian provinces on health and social care throughout the province. So we invest a lot in our healthcare system in order to achieve what the goals that we set for ourselves for distributing access to care. Despite that, we also have some concerning health outcome metrics. From 2020, we did a comparative study. My partners at Quality of Care NL, a unit within our Faculty of Medicine, comparing Canadian provinces on a number of health and social care outcome metrics like mortality and cancer rates and cardiovascular rates and chronic disease. We routinely ranked 10th out of 10 Canadian provinces on all of those outcome measures. And recognizing that in Newfoundland and Labrador, we undertook a broad consultative process that we called the Health Accord. And between 2020 and 2022, that committee did work to reimagine what health and social care would look like in Newfoundland and Labrador and set an ambitious goal of, within 10 years, transforming our health and social care system to take us out of that 10th out of 10th ranking and somewhere closer to the top. So that proposed a number of important changes to our system that involved refocusing on social determinants of health, reallocating resources to preventative versus downstream care, and primary care was no exception to that process. In fact, the reimagining of primary care in Newfoundland and Labrador began years earlier with the uptake of the patient's medical home model from I guess it was the Canadian or College of Family Physicians of Canada. So that was one of the foundations of this change that I'm going to describe for you in a minute, that put an emphasis on interprofessional models of care and team-based care in primary care settings. And so the upswell of interest in team-based models of primary care and the restructuring project that's currently ongoing for our health and social care system broadly sets the tone for what has happened in the last 2 years or so. In early 2023, as a part of the Health Accord's recommended actions, the province of Newfoundland and Labrador, specifically its Newfoundland and Labrador Health Authority, or NLHS, we have a single, like Prince Edward Island, a single health authority in our province. It was recently amalgamated from 4 regional health authorities. And the powers that be said there shall be these units called family care teams. They follow an interprofessional team-based care model, and they set the goals of having integration within communities with other clinics in those communities and with secondary care institutions wherever that might be located. These family care teams have a wide diversity of professionals and there's a lot of diversity between teams as well about who is employed at each one of these teams. Now that's a complex process, of course. The people who are available to work in these rural communities from each of those different professional backgrounds will vary from one community to the next. Some teams are quite small. They might involve only a nurse practitioner and a registered nurse with clerical support. Others are larger and further along their, as Matthew put it, a maturity process. And they may be anchored by a team of nurse practitioners and family physicians with social workers, registered nurses, physiotherapists, some constellation of a wider base of interprofessional providers. In these family care teams, there will also be hired, not yet, but in the future, individuals in the roles of social and or Indigenous patient navigators, as well as what's called patient care facilitators, who are like case managers, who are going to help the client base in each one of these teams to get connected with all of the resources they need in their team and in the wider community, following like a patient's medical neighborhood model. That's an extension of the patient medical home. And what's happened is, since these family care teams have begun their work, and as of September 2025, we have 21 of these teams in kind of the fully operational stage. 2 teams currently in development, by which they've got budgets and they've got approvals, but they are still in the hiring process and haven't begun their work yet. We're on the pathway to having a total of 35 teams across the province when we finish this transformation. I don't know when that's going to happen, and we'll keep trying to make progress towards it. As I was saying, though, as we started down this road, the people at NLHS and the people in the teams themselves have recognized that it was not sufficient to put these individuals in the same location and assume that they were going to work well together. Because our center does a lot of work previously, thinking critically and applying the concepts of interprofessional collaborative practice, we got wrapped in to develop a suite of programs and resources that could help family care teams really gel, really come together and optimize a type of care that goes beyond multidisciplinary and hopefully achieves the standard of interprofessional collaborative care. And in really rare circumstances, but with a lot of effort and practice, you can reach what's known as transprofessional care, where people's roles blur and fit so seamlessly together with the overlap that's possible that they have even better outcomes. So that's where we stand right now. Through our center, we have a training program developed for family care teams that has three main components. The first is a program we call the Foundations Program, which is a combination of online short modules that are targeting specific collaborative practice competencies, either from the Canadian Interprofessional Health Collective's competency framework, or to dig into collaborative practice issues that we learn about through our consultations with our stakeholders, through regular needs assessments and evaluations that take place in the family care teams. And we're grateful to the other teams of people in NLHS who are helping us to understand what they're hearing on the ground. So we'll design these modules in a way that makes them very accessible to care providers, recognizing they don't have a lot of time to sit down and read a book about collaborative practice, but maybe they have 10 or 15 minutes to do one of these modules at some point during the day as a refresher for the basics of collaborative practice, and critically, how they apply for family care teams in their local contexts. We also offer workshops through the Foundations program. Those workshops might be virtual for anybody in the province who might be interested in learning about that, or they could be customized for teams specifically. If they raise an issue with communication, with conflict management, with shared leadership, we can design a workshop or adapt one that already exists to meet their needs. We have a monthly webinar series that happens on the first Wednesday of each month, and we'll be holding the 15th of these webinars this December, on December 3rd. But we've had webinars on topics that you can see on your screen right now, like Indigenous patient navigation, social prescribing, and trauma-informed care principles, and what they mean for primary care in Newfoundland and Labrador using the structures that we have available to us. And we've compiled and curated a list of our own resources and those from outside of our regional little area onto a website we call our Family Care Team Resource Hub. That's where you can sign up to complete the modules and attend the workshops, to attend our webinars, or to peruse all of the other practice supports that we can make available to our care providers and stakeholders. So not to take up too much of our panelists' time, but to return to the question that we're here to answer today, if we're on a roadmap, are we there yet? The answer is yes, because we are in a far better position, at least in Newfoundland and Labrador, to say we have a model of team-based care that has come from the right place through consultations, through system reform, and we are far better off now than we were without any family care teams, without the support that comes along with the directive from the top that says there will be these teams and this is how we're going to try and organize our work. But the answer is also no. We don't have all our family care teams operating. Those family care teams that are operational still require support. And I think, as much as I want to say that this is a linear process with milestones to reach on the way, it's not about whether we have reached our destination. It's more about looking and realizing how far we've come and acknowledging how far we have to go. And so it's not a road. It's a Mobius strip where you continually move towards your goal, and without noticing it, you may already have come around to the place you've begun, but you're in a different orientation, in a different place than when you started. So that's what I've prepared, and maybe I can hand it over to whichever of my fellow panelists goes before or after me.
Thanks, Adam. I'm going to quickly go to Megan next, and then I'll come back to Dr. Smith. So, Megan, do you want to introduce yourself, and then we'll start our discussion, and then we'll go from there.
Thanks so much, Matthew. So my name is Megan Kiley, and I'm a first-year medical student. I'm at the regional campus of Memorial University of Newfoundland in PEI. It's the inaugural class, so I'm very excited for the future ahead and the learning experiences I have coming. I did my undergrad at Memorial University in biochemistry and stayed to do my master's in medicine and cardiovascular science. So I have a nice exposure to the Newfoundland health system and also in PEI, but just excited to continue to learn. Thanks.
That's fantastic, Megan. And I think, for the people who have joined today from not PEI or Newfoundland and Labrador, this theme will come up a bunch in terms of the partnership and some of the similarities and differences. And thanks, Adam, for illustrating some of those nuances of progress in Newfoundland and Labrador. Before we move on, I just wanted to circle back, Megan. You said you're excited. So what are you excited about? Like we've had a lot of this conversation about transformation and change and shifting what primary care practice looks like. For you as a student, what gets you excited about your future career?
Yeah, thanks. So I think knowing for a long time I was interested in medicine, I've always had an interest in primary care. But today in PEI and of course across the country, seeing the difference of the implementation into models such as the patient medical home, it excites me for the future of working in a collaborative team-based care center and to be able to work with a lot of different colleagues and professionals that come with their own expertise and their background, and have the end goal together to kind of facilitate the best coordinated and comprehensive care for patients. And in particular, with being a new learner, just in my first year, having exposure to patient medical homes from the start, and also being provided the tools to become the best team player I can be. I think our program's been set up quite well to teach us what we need to be taught to become team players and also to, have early exposure to the patient medical home and PEI and kind of, see what that's looking like and be ready for it for the future when we become practitioners as well.
That's great. And I think it's a great segue. It's unfortunate the video didn't work. That will be in the slide deck that gets posted online, so viewers can go and watch that video on their own. But I think it's also a great connection to my next question back to Dr. Smith. And if you want me to share those other slides, you can speak more about this partnership with Memorial and how our Faculty of Medicine at UPI is being tailored towards rural team-based primary care.
Yeah, that'd be perfect if you would put those slides up.
Are they up?
Not yet.
What is happening here? How about now?
Yes, perfect. Okay. So thanks everyone for the opportunity to talk to you here from PEI about what we're doing on PEI. I think just to echo Adam's and Megan's comments, what we're starting with is as a regional campus of Memorial University, and So, as many of you would know, there's upwards of 20 or so regional campuses across the country now. It started in 2004 with UBC in Prince George and Victoria. It's a well-proven model to distribute medical education, to take advantage of clinical teaching capacity outside the major centers, and to successfully recruit and retrain doctors in areas that previously was a challenge. So it's a good model and it's quite effective. And we're thrilled to have Memorial as a partner doing this. And UPI is facilitating the delivery of Memorial's curriculum on PEI. There's 20 students that started the third week in August. Interestingly, this is the fourth regional campus that started this year. With Lethbridge and Grand Prairie and Cape Breton, all starting regional campuses with nearby universities. So that was a bit about, I mean, the video was a bit about the challenge in primary care and what UPI hopes to achieve in solving that problem. And as I say, we are launching that process by this partnership with Memorial. Do you want to go to the next slide, Matthew? So, I mean, one of the things that if you're ever vacationing on PEI, you've got to come check out our facility. We have an amazing building, which Megan is in every day. But it is, 5-story, 138,000 square foot building. The unique nature of this building, and is like many, it's interdisciplinary, but it's very also closely tied to the healthcare system. So Health PEI is operating a 10,000 patient, 7 prescriber, patient medical home, just off the main entrance. The offices for learner wellness and success are just right across the corridor from this patient medical home, and it is the model that Matthew has talked about, and similar to what Adam is talking about. It is, but it is more than that. In the PEI model, it is really intended to be a bit of a pilot site for patient medical home evolution. So not only will our learners be among the only learners in the country that have team-based um, primary care role modeled from day one of medical school, but they'll actually be seeing that in a laboratory in many ways as we evolve patient medical homes on PEI. A lot of that piloting will be done in the patient medical home that's in our building. We're training learners in team-based care models. We'll be integrating nursing, kinesiology, and the other um, uh, health professionals educated on campus. Can we go back to the previous slide, Matthew, just for a minute? One of the key things about this building is actually world-class simulation facilities. And so there are 11 high fidelity simulation rooms in this building, as well as the usual examination rooms that we teach clinical skills in. So those 11 high fidelity simulation rooms include 2 apartments, another that's set up as the back of an ambulance, and some of the more traditional simulation rooms that are set up as hospital wards and trauma rooms and operating rooms and such. But the capacity to do that kind of team-based simulation is unsurpassed, I think, anywhere in the country at the moment. It extends beyond the building. So there's in the parking lot, there's a truck with UPI simulation all over it and a trailer, and we can take those high fidelity mannequins anywhere in the province. So just in this fall, we had a rural facility that had a bad outcome. They talked to their superiors at Health PI who said, you contact UPI. And we sent a team to that healthcare facility to actually rerun that scenario where they had the bad outcome and work with that team so we can project this team-based training using simulation to any community on the island. And go to skip 2 slides. Yeah. Some of the other things that we're doing is we're looking to establish a research chair in rural health. Again, this is an effort to use research to drive innovation, and doing that by partnering, attract new fundings, and link the university, as I said before, to the health system and the community. We have just finished recruiting a faculty position, which is actually a nurse practitioner who's going to have a joint appointment in medicine and nursing. And the goal there is not only to help drive the interprofessional education curriculum, but to do also to facilitate the research on team-based care in the patient medical homes across the province. Next slide. Yeah. So the next phase in all of this, and again, with this fabulous partnership with Memorial, not only are they delivering their curriculum, and it is a curriculum that leads the country in people doing family medicine and people practicing in rural locations. So it's a great partner for PEI and UPEI. Um, but there's also an agreement that we will develop what's been called the joint program. It may be a misnomer, but it will be a model where we will actually be able to tweak that curriculum in such a way that we take the very best of the memorial curriculum while being able to adapt parts of it to the unique nature of practice on PEI. And so I think this is very, very exciting with the idea of being able to do this, given the resources, the small population base, we need to start slowly and go slowly, but at the same time have the opportunity to partner with a wonderful program, and the opportunity to adapt that program to unique nature of PEI. I know Matthew's probably covered this in previous presentations, but the unique nature of healthcare on PEI needs to be understood. The fact that we are in the most densely populated province in the country, and yet it's entirely rural, that sounds contradictory. The fact that half of our tertiary and all our quaternary services provided by other providers all adds to how healthcare is delivered, and how, in many ways, primary care is delivered differently here on PI than elsewhere. I'll stop there. I'll be happy to answer any questions as we go further in the conversation.
Sounds good. There was one question that came in through the Q&A, so I'm gonna direct that to, I think it was while Adam was speaking, so I'm gonna direct it to him. And just any other questions that attendees have, feel free to put them into the Q&A, or raise your hands. And so the question was, what is your strategy or approach to support unattached patients, or do you have unattached patients? And I know that we've talked about that in the PEI context in our second session. And so if this question was directed towards Prince Edward Island, I'd encourage that participant to go back to session 2 and watch that one. It's on the website. But I will let Adam answer that question in the context of Newfoundland and Labrador.
Well, about 2 years ago, our Newfoundland and Labrador Medical Association was estimating that there were about 90,000 Newfoundland and Labradorians who were without a family physician or primary care provider. So there definitely are a good many unattached individuals in the province. I'm sure that number, I'm hoping, has gone down. In about 2023, coinciding with the introduction of family care teams, the province opened a portal called Patient Connect NL, and anyone who is not currently attached to a family physician or primary care practice can register their name there and can get in the queue to be registered. So there are people who are registered but not formally rostered with the family care team. We call those individuals connected but not attached. And so there's a staged approach, I think, for getting that large group of our citizenship from where they were to where they are, but it's going to take time in order to address all those. Family care teams are a part of that process. When family care teams open, their first push is to begin, rostering as many patients as they can safely do so. But I think there is also a process that needs to happen where those individuals change the way they think about primary care and what it means to be attached to a primary care practice. Their traditional orientation is that they have a family doctor and they go see that family doctor for whatever it is they might be concerned about. In a family care team, the process is going to look and feel a little different. The first person you talk to is not likely to be your family doctor. It'll likely be an intake nurse or patient care facilitator who's going to do an assessment and a screening of all of the different health needs you might require. And that would include social determinants of health and the many other dimensions of your wellness that different members of a family care team can address. So you may show up at a family care team and actually see several other care providers to address your immediate needs before you have a conversation with that family doctor who's that anchoring, prescribing individual on that team. And it's just a different way, not just for care providers, but also for patients to access that care. So, that's what's happening here, of what I'm aware of. But I'm sure that Prince Edward Island is facing its own challenges for rostering. It might be a little easier to get from one care team to the other on your island, but nevertheless, those problems are persistent across Canada as well.
Yeah, thanks, Adam. It reminds me of I was in Ontario last month, and I heard the term. I think they're saying, and maybe someone from Ontario can correct me, transitional attachment is the phrase in terms of kind of the stages from not attached to completely attached. So yeah, I think that's a common theme. Megan, I'm going to come back to you, and so we're talking about changing. A lot of change, right? And both in terms of how you're receiving the education that you're getting, but also the changes that are going on in the practice environment. And so my question to you as a trainee is, what would you share both to your peers, but also to practicing clinicians, system leaders, researchers? What are the things that you think we should be paying more attention to?
Yeah, thanks for the question. So I think it's like everything when you're, trying to implement change and trying to create a new, environment or a new process. There will be some struggles that go along with it. So I think an overall topic I would think of is, um, to remain open-minded, whether that's with like people that I'm working with right now in my program, or whether that's people that have been working in the healthcare system for a long time. The more you can remain open-minded and just kind of embrace change, I think kind of leads to more positive experiences and productivity, as well as, we as medical learners and most individuals in the healthcare system took an oath to lifelong learn. So I think this is kind of a major part of this lifelong learning is for physicians that are currently working in the healthcare system or interprofessional partners as well, that it might have been a certain way for a long time. Say a physician had a clinic and they were used to managing it all on their own, to embrace that change and kind of embrace the lifelong learning opportunities to adapt, because I think we're all here for the common goal to, better patient care and better primary care access in PEI and across the country. And by doing that and by embracing those changes, you can also help the patient outcomes and their experience as well. And I think for sustainability too, implementing feedback and, embracing feedback as well, but also communicating. So for researchers and individuals that are looking at how these systems are working and taking in that data, to kind of maintain communication and maintain that like open line communication from feedback and taking the feedback and implementing strategies to kind of increase the changes. I think sometimes we think things are changing and we might have frustrations about them or thoughts, but and we're not sure if it's being changed in the background or being worked on, but it probably is. So I think the more we can communicate and and discuss those experiences, I think that it's keeps everyone positive and works ahead. But at the end of the day, I think we all have the same ideas and mindsets. I always add one more point here too, because I think I'm rambling, but for students like myself, I think to continue to embrace the opportunities you have to work in these patient medical homes and primary care settings that provide collaborative team-based approaches. I know we are, of course, lucky to be able to be put into these placements quite often, but so for allied health professionals and nursing teams to, when you get an opportunity to take a placement, I think to try and get those placements in these team-based care settings to experience this as a student, I think will better you as a future provider in the healthcare system. Thank you.
Yeah, thanks for that. Because part of what I heard from you makes me think a lot about the conversations that we've had more broadly nationally through the consortium about learning health systems. And Dr. Smith, I'm going to come back to you about that, because we kind of skimmed over a little bit in terms of that you're also the chief academic officer for Health PEI, this connection between the university and the health authority. And certainly, looking over your career, I know we've had this conversation of being an agent of change is not new to you. You've done this in a couple different provinces. And so I guess like part of this is, what do we share to other rural settings, but also what are some of the lessons learned that that can be adapted from one province to another, or from rural settings to urban settings? Yeah, thoughts on the national conversation here.
Well, I think one of the exciting parts about being on PEI is to be the opportunity to be a laboratory. I mean, given that we're a small size, allows us to do things if we choose to put the effort into it. I think just to pick up on one of Megan's points, I think we could be the first place where we start distributing other health professional programs. So why couldn't we be a regional campus for Memorial or Dal with regards to pharmacy and physio? And wouldn't that be an interesting model to have students in an interprofessional rural setting from different universities doing programs together? So that's at that educational level. I think one of the advantages, I mean, having been a dean at a bigger medical school, there's a tension that exists between the basic science kind of traditional kind of research and what the healthcare system wants to do, which is often much more applied, much more more bordering on quality improvement activity as opposed to pure research. And whereas we don't have the history of either a lot of clinical research or a lot of basic science research happening on PEI. So how can we leverage that close partnership between Health PEI and the university to start doing the kind of research that we're talking about here, and that's certainly from the beginning. SPORE and this primary care network have all advocated for, is to try and so I think we have a really unique opportunity to maybe be moving towards a learning health system because we don't have that kind of historical bodies of research and the two different worlds competing with each other that may exist in bigger centers.
Yeah, thanks. So there's one that just came in. Let me just look at that. So the question is, while team-based primary care is often seen as the way forward, what do you see as its downsides or unintended consequences that we should be mindful of as we expand these models? I'm not sure who wants to jump at that one.
one of the things that I meant to follow up on as well before with regards to your previous question, and then I'll go into this one, is also team-based care in a rural setting is very, very different than the team-based care that happens in tertiary settings. I often use the example that if you put a medical student on a dialysis unit, the social worker will know more about about electrolytes than that medical student probably ever will, if they don't become a nephrologist. And so whereas if you put people in a team-based setting in primary care, it's care that is visible and easy to relate to. And so some of the best teamwork I've ever seen has been in rural-based primary care settings. So I think it's a perfect place to teach team-based care. The second point that I think that I wanted to make, the challenges are that is teamwork is hard, and that's true everywhere. And so in rural settings, when the teams aren't working well, there's kind of nowhere. It's not easy to change teams, and those are the human dynamics that come into team-based care, which I think is probably still one of the biggest challenges.
Yeah, I'm gonna loop that back to the conversation that Adam and I had when we were preparing for this session, and just knowing that we're coming up on time, and so Adam, I just wanted to go back to you about that in terms of things that the practical advice, in terms of an exercise that anyone can do to illustrate the value of teamwork, whether that's urban or rural, and speak a little bit about that high level of social cohesion that happens in rural settings. And I think that ties also with the question that came in from O'Neill around, can you comment on efforts to test and teach shifting frontiers in scope of practice, which is typical of a rural practice setting? So some of that in terms of while we're well suited for team-based care, it also there's a little bit more adaptability that happens in that space also. So I'll pass it to you, and then we'll wrap up.
Well, I had a very short list that answers that question about the challenges of family care teams, or at least any team-based primary care unit that's operating no matter where it is. The three things on that list are scarcity, isolation, and novelty. So in rural areas, you'll see scarcity of resources, and that has implications for how teams relate with one another. Where there is not regular access to all the specialized skills you need, what you see is a lot of overlap between care providers' roles. They have to share their scopes of practices a little bit more in order to create the web of support that those communities need. Second one is isolation. It's not that rural communities are, out in the middle of nowhere. It's that teams working in one community may be solving problems that teams in the next community have to solve and haven't figured it out yet. And so connecting teams with one another in a community of practice is going to be a really important way to create some sort of consistency from one team to the next, but also gives a voice to those unique solutions to those problems that people in really high functioning teams have already solved, and now it's time to try and share what they learn with others. And the third one was novelty. I mean, many primary care providers are moving from what was a very siloed, multidisciplinary way of practicing to a more co-located, very interprofessional and very integrated way of practicing. And because that's new to many care providers, it is going to take practice to get really good at it. And that will come with time, but it also requires support to help them get there as soon as possible because of the stakes that are at play when you're talking about making this type of change work and seeing the types of outcomes that you want to see because of it following your investment in that structure. Maybe that doesn't quite follow from what you were talking about, Matthew.
No, it's okay. It's just it doesn't just happen by the snap of the fingers.
No.
And
that's okay, right? That's okay.
Oh, for sure. We're coming up on time. I think I can squeeze in maybe one more. Apologies, Sherry. I'm going to skip over yours because we did address one of them. So I'm going to go to another question from Monica, which is for Dr. Smith, about the introduction of physician assistants and thoughts on the opportunities for integration of physician assistants into team-based primary care.
Yeah, so this is a rapidly changing area. I mean, before I left Saskatchewan, we had got the approval from government to start a program, and my colleagues there have got it up and running. The Dalhousie started one in record time in the last year as well. The province is committed to adding physician assistants to the program. I think. And we're talking about actually purchasing some seats at Dow in their physician assistant program. I mean, from an educational perspective, in a limited clinical teaching capacity environment, one of the challenges is it's another group of learners to find clinical teaching resources for, which is indeed a challenge. I think. I think there's not many of us that have worked yet in a team-based environment where physician assistants have been present. And I think the challenge there will be, again, to, figuring out how to make that work in an environment where you're introducing other health professionals at the same time. And so part of the challenge in the team-based client, I mean, has been actually, what's the role of the nurse practitioner, and the physician? And now we add a fourth complexity by saying, what's the role of the PA in that same setting? So on the other hand, from what I've heard in the literature I've read about PAs and the skill set that they bring to the table, they can bring problem-solving abilities that are augmenting the nurse practitioner and physician. So I think it's all possible. It's just going to be probably a little messy at first. Yeah.
Thanks. And we are coming up on time, so apologies in terms of the questions that we didn't get to. I'm just going to put up my contact information. So if there's other questions, feel free to email me, and I can certainly bring them to the panelists as well. I want to say a huge thank you to our panelists for today's conversation. I think it was really a great way to cap this learning series. I want to thank everyone who attended, and certainly to CPCRC for providing us the opportunity to present this whole series. It's been quite an adventure. So with that, we'll say good day, and thanks everyone for joining.